All right, we're live. Good morning, everybody. My name is Dr. Paul Barish. I'm coming to you from Chicago in the US of A. And we're here today to have a panel with a distinguished group of experts from around North and Central America to discuss issues around COVID. As you all know, COVID has been an extraordinary affliction on society in the last 6 months, with over 12 million infected people, as much as 700,000 dead. In North America, over 4.5 million infected people, and about 195,000, perhaps as much as 200,000 in North and Central and South America. This pandemic is unique in the sense that it's moving quickly, it's affecting everybody, it's upending our economic, social, and political systems, and it has a unique way of separating and undermining and perhaps exposing many of our weaknesses and challenges in our public health and economic systems. The panel today will discuss a variety of themes that we've laid out on the website, and speaking to how well were we prepared as a society, particularly with a focus on North, Central, and South America. Number two, how was the economical, political, and if you will, the broad communitarian responses in response to this unusual challenge? How did we respond as individuals, as clinicians, as clinical leadership, as society leaders, and as a community? How well are we doing in this part of the world? What can we learn from other countries in Asia, in Africa, in Europe, in Australia? Most importantly, how do we protect marginalized citizens, people of disparities, with low social and structural economical disadvantages? It's clear that there are challenges that are particularly and uniquely being exposed in that regard. How do we protect our health workforce? We know that they've been extraordinarily vulnerable, with thousands of healthcare providers who have died. Some estimates close to 450,000 have been infected. And above all, what does the future look like? How do we go back to work? How do we go back to healthcare? In fact, how do we go back to wellness? As you all know, this panel is part of WISH, the World Health Institute of Society. And really, WISH is all about how to focus on the SDGs, and particularly SDG 3, that is to say, the wellness of the population, both before COVID, during COVID, and after COVID. So I want you all to be thinking, as you think about it and respond to the comments, how does this all connect to the broader goals of advancing the UN Sustainable Development Goals, and particularly focusing on the mental, physical, and spiritual wellness? So to help us off, I'm going to invite each of you to introduce yourself. I'm going to start from my screen first. Rami, do you want to introduce yourself?
Sure. I'm Dr. Rami Ahmed. I'm a professor of emergency medicine and a simulation fellowship director. I spend the majority of my non-clinical time training personnel from all specialties using medical simulation as a training methodology.
Thanks. Louise?
Good morning, everyone. Thank you for the introduction. I'm Dr. Luis Martinez. I'm a Mexican physician. I'm passionate about global health. Here in Mexico, I'm the director of the Global Health Chapter in the Mexican Society of Public Health. And also, I'm a global health researcher at the London School of Hygiene and Tropical Medicine. It's my pleasure to be with you all here.
Thank you, Luis. Mark?
Oh,
you can't hear Mark. You got to unmute Mark.
Sorry.
Thank you.
It's a pleasure to be here. I'm Mark Nichter. I'm a medical anthropologist from the University of Arizona. My training is both in medical anthropology as well as clinical anthropology and also public health. I have worked on a number of different pandemics in both South and Southeast Asia and West Africa. And I'm very interested in building communities of practice, bringing different groups of people together to address pandemic response instead of reaction.
Thanks, Mark. Don?
Good morning, good afternoon if you're in the Eastern Zone. I'm Dr. Donald Donahue. I'm a professor of healthcare administration and global health at University of Maryland, Baltimore. I also sit on the board of the World Association for Disaster and Emergency Medicine and function as the editor-at-large for the journal Disaster Medicine and Public Health Preparedness. And I share the same passions and the same goals for equity, for access, and for responding to this truly unique pandemic. Thank you.
Thanks, Don. And finally, last but not least, Brad.
Thank you. Thank you for having me. My name is Brad Dreyfuss. I am an emergency physician and public health specialist at University of Arizona, and I've been working in global health for about 20 years with my colleagues in Uganda, and have been working on the preparedness piece here for healthcare workers across all designations through co-founding and getting up and going HCW hosted.
Super. So, Rami, you've been in the trenches for the last several months, and some would argue that one of the reasons why the U.S. healthcare system has been struggling has been the fragility of the integration between the emergency department, the community, and the continuity of care. From your vantage point as an emergency medicine doc, how do you see COVID being handled, and what types of lessons might we learn in order to be ready for the next waves that are likely to come our way?
I mean, I think a big issue is the misinformation and the approach that we're taking as a society, as a body of experts, and sort of confronting that misinformation in a way that really is a public health issue and a public health strategy that needs to be further emphasized. It's amazing, being sort of a frontline emergency medicine physician at a major level 1 trauma center, having 3 large tents planted outside of our facility and ready for sort of a large influx of patients. The amount of preparation it takes and the amount of not only effort it takes to take care of patients on a day-to-day basis with a regular chronic surge of patients with their normal complaints, but the addition of assuming everybody at this point now is exposed to the virus and providing the highest level of care within the limits of the equipment and resources and human resource that we have, is very challenging. So on top of identifying the disease, the virus, providing that highest level of care, we also have to provide information to the patients, both the critically ill and the ones who are not critically ill, because, for example, we've had patients who come in with non-specific complaints, and for whatever reason they trigger getting tested. We then have to provide, a significant amount of counseling to them if we are going to discharge them, if we identify that they're positive, so that they don't go and infect, their community, their families, and those kinds of things. So I think, getting out in front of it in terms of information, as well as when you have the patient with you at the bedside, providing that sort of optimal level of counseling and care can really help sort of spread further, transmission of disease.
So Don, when we think about emergency health preparedness and the role and importance of communication, prudence, policies that are common, how well have we done in North America? And what are lessons that we might be able to improve around how to better communicate core messaging?
Not well at all, Paul. Part of the issue has been while it's better than it has been in the past, the dichotomy and the gulf between public health and medical care. Here in Washington D.C. and during the anthrax attacks, the public health departments did what they did, but nobody reached out to the emergency departments. So they operated in isolation. There's been a degree of that. And as just mentioned, there's been a lack of consistent. Not that we change, because change, this is a novel disease, and we're learning things as we go. But a lack of consistency across jurisdictions, a lack of leadership from the federal government, and I think we just haven't really we haven't paid enough attention to the lessons we've learned over the last years.
So do you think the challenge, Louise, is because it's unclear who's in charge? Is it a governance problem? Is it a policy problem? Is it an implementation problem? Help us think about why are so many countries, for example, in Central and South America, struggling with inconsistent implementation of policies? And again, what are some lessons to think about from a governance perspective?
Of course. Thank you, Paul. I believe that what we are seeing here in Mexico and Central America is similar. Of course, it depends on the country, but we need, we can understand that there are separate spheres. For example, you have the leadership, the policies, the social structure, and the community. But first, you have a solid preparedness strategy to deal with this pandemic, and then you have to connect all these strategies together so they can work together. I think this is important, that we have to understand that COVID-19 is not a global political crisis. It is a social crisis, a global social crisis. And COVID-19 is not a 2030 agenda also. This is a situation in addition to the pending agenda that we have. And here in Mexico, one of the pending agendas is, for example, relative poverty. 60% of the people in Mexico lives under the poverty line. So you can imagine that in this moment, without the proper frameworks, policy frameworks, the right leadership, the right communication, the necessity from a big part of the community to go to work every day, that you have an organization here in Mexico to really deal with the pandemic. And we can see a lot of problems, and we can focus on a lot of problems and worry about community engagement. On one hand, regardless of the policies, for example, I would like to think that preventing the infection of and the transmission of COVID-19 is quite simple. You have to wear a face mask, you have to maintain your distance, and you have to wash your hands as basic implementations. You don't need quite high technology to do that, you know. The problem is that the community is not really engaged. And this is result not only from the poverty and education profiles of the population, it's also because there is no clear strategy in the policy level, in the clear leadership, and the support, the economic and social support, so the community can be part of a collective response. And that is what is not happening here in Mexico. We can see examples, for example, in New Zealand, or Germany, but in Mexico, every sector is separated. There is no clear leadership. Mexico has 32 big regions, and every region is handling this situation in a different way. So we need clear leadership and perhaps consistency in all these elements, and that is what is not happening right now.
So, Mark, you know, as we think about the power and importance of trust and the power of communities to work together, you know, it strikes me that when you look at countries that have done really well in managing the pandemic thus far, like Taiwan, like New Zealand, like Norway, there's a strong discussion of the importance of civic technology, of the power of the community to come together, to listen, to share, to help. What is the role in the US, for example, and how can we move from a sense of disparate communities, both from a socioeconomic sense, but in general, disparity in how they go about listening and how they go about following directions and how they go about caring for their community. So what is the element of communitarian values that needs to be brought forward in order for us to learn from these last 4 months, as particularly in the US, where we lead the world in the number of infected people and the number of people that have died, 153,000. What is the power and importance of the community in order to move forward?
Well, I think that one of the former speakers kind of nailed it when he said that what we're looking at now is the necessity of really a very close interaction of both clinical and community interventions here, both medicine and public health working hand in hand. A pandemic like this is never going to be solved just by having better clinical services until we get some sort of magic bullet like a vaccine. So the community obviously has to play a role. The problem in the United States is that we have a very poor sense of health citizenship. Recently, a bunch of us wrote a paper critiquing the Robert Wood Johnson concept of the culture of health in the United States, because there is no culture of health. There's divisiveness. It's not just a question of misinformation. It's a question of disinformation, and really the politicalization of this entire pandemic And this has confused people. It's created a pandemic. It's created a panic that is very palpable. People are very confused. We have news 24/7 talking about COVID. People kind of become saturated. But what we don't have is this sense of citizenship that you've had in other countries. Take a look at a country like Czechoslovakia that where people never wore masks before, and within 3 or 4 days of the government explaining to the public that this was necessary to control the pandemic, people created their own masks. They didn't even purchase them. It was a massive movement. This is different than Asian countries where you already have this sense of health citizenship that has been ingrained perhaps through more authoritarian governments. Although if you take a look at a success story like Vietnam, Vietnam was not mandated. People were not forced to do this. They did it immediately. So I think that the health citizenship issue really comes down to both leadership and also public understanding of science and trust. And we just don't have a lot of trust right now. I think our biggest problem, and the problem that is going to plague us for some time in the future, is mistrust, which has been fanned by political efforts. Until we solve this problem, we're in big trouble because people are getting their information largely through social media, not just through news sense. And even people who have looked for leadership in this country through people like Dr. Kelsey, still there is this identity issue that is associated with trust. It's not just a question of information. It's really a question of identity, of people identifying with a particular political party or a particular ideology. And that has really muddied the waters.
So powerful message, Mark. One of the most challenging things in this pandemic, and I've, as a clinician, I've been involved in 3 different pandemics. I've never seen the incredible insult on healthcare providers as we've seen in this pandemic. So thousands of first and primary care providers have died. Hundreds of thousands have been infected in quarantine. An incredible emotional, spiritual, and physical toll on healthcare providers. In addition to the fact, this deep and growing sense of mistrust against the administration. And so, Brad, I'm wondering if you might talk us through some of the ideas of how you see first what we've seen so far, and how do we move towards building more trust amongst the healthcare providers who are at the core of a response to this pandemic, something that can't be replaced easily, something that already has had incredible drag on the inability to deliver both COVID care and non-COVID care. So what are steps going forward, and how best to nurture this incredible loyalty and commitment of our healthcare providers?
Yeah, thank you very much. I think a lot of it comes down to what some of the structural determinants would be. And if we can take a step back, and if you look at our healthcare system that is about approximately half publicly funded, but privately implemented, it's become pretty clear over the last 20, 30 years, maybe go back as far as 40 years, that we don't have the ability to have a preparedness model. We've had a productivity model for staffing, for supplies, for thinking about the role of your workforce and your human resources. And on the human resource side, we have become very much of a line in the profit loss spreadsheet, instead of thinking about us as parents and family members, as community members, community leaders, et cetera. And so there's been underutilization and undersupport. And we've had opportunities to address this. We've had H1N1, we had Ebola, billions of dollars were spent in preparation, but in a structure of a corporate healthcare model that's focused on efficiency and not thinking about worst case scenario, but what is the typical, with no backup, that's been very problematic for staffing and for supporting our workforce. And when that happens, there is zero trust within the workforce. When I have 30, 40, 60, 70 of my nurses and techs and others who are furloughed, and they are like, okay, now I don't have a job. I don't know when it's coming back. I'm going to go find another job, and one that I have more confidence in, that I will be able to provide for my family. I'm really thinking about us and not just our 9 to 5, or for me, 11 to 8 a.m. role, but thinking about us as members of the community. we need a community-based pandemic preparedness model that really includes the human resources as well as the material resources.
Don, you've been involved with helping people get back to work, universities, companies, corporations. What is your sense of how well in the U.S. we've been implementing those recommended strategies for going back to work safely? You're mute, Don.
Always. I believe that I think the implementation is going better than the official response, but most of it's coming from grassroots. We have, as you all know, Paul, my family, we moved a couple of months ago, going to Home Depot, the hardware store. There's like a phone booth with plexiglass, and nobody touches anything. I've seen better. I've had my vehicle in for routine maintenance. When I got there, the doors were open in the office. They were about a third of the number of techs there helping, and I had a woman there just cleaning everything, just sickly cleaning all the windows, cleaning all the handles. So I think some common sense approaches: open windows, increase the air circulation. It's the amount of turnover in the room of the HVAC system. I think it's generally going well. There are those disconnects, and it's having a massive impact, which is part of the politicizing of the issue on small businesses, on restaurants. There are people that are just we haven't, absent the vaccine, absent greater understanding of the transmission and the prevention. These people are economically dying. So I think we're well along. We're well along the way, but we're not there yet. And I actually want to add something to what was just said. I think in the healthcare force, the heroes, I see a correlation to the military. 10 years ago, in the U.S. at least, there was a recognition of, thank you for your service, you're a hero. But that cohort of people who serve is distinct from the general population. They're a separate subpopulation, and I see that among the fact that healthcare people are being laid off doesn't resonate with the layperson. They don't understand what's going on. What they also don't understand is when you see the great reports on the news of the people all gowned up with masks and hoods and all that. They don't understand that these people are working 8, 9, 12 hours without having anything to drink, without going to the bathroom, because in order to do any of those mundane things, you have to take all that stuff off and decontaminate and then put it all back on again. So, the depth of the impact on the frontline people that are facing this, I don't think it's truly understood by the general public.
So that's a really important point. So I'm gonna ask Rami a question, and I'll come over to you, Brad. Rami, as an expert in PPE, do you think the present PPE is well suited for an 8 to 10 hour shift in the emergency department?
No, I think anybody who's used it more than a few times realizes that there's significant limitations to it, both in the ease of putting it on and the risk of contaminating yourself when taking it off. And looking at some of the research the last several years, there really hasn't been any significant improvements in the development or improvement or optimization of PPE, because there really hasn't been a market need for that, right? I mean, a lot of innovation is driven by the market, and if pre-pandemic, you could buy a box for X number of dollars, and there was really no demand for improvement because the consumers weren't, utilizing it to the level that they are now. You're not going to put money into a product that people feel is adequate. But now that it's, front and center, and the thing that's keeping us from being, potentially put on a ventilator, I think you're going to see a lot of, and there's already, as you've already seen, a lot of research going into now how we can improve and optimize that. So that's some of the work that some of me and my fellows are working on, and working, obviously in a interprofessional fashion with scientists, engineers, biomedical engineers, to try to further develop the next phase of that. Because if anybody who's worked in the front line, even doing a resuscitation on a critically ill patient, wearing an N95 and a face shield and those kinds of things. As you're all aware, communication in the regular day-to-day environment pre-pandemic was already challenging and something that we were continually working on improving. And now you've added several layers of protective equipment, which makes it even more challenging and induces several latent safety threats and other challenges and stuff. So there's definitely a huge need to sort of work in this space to optimize PPE development for future pandemics.
Absolutely. Brad, you had your hand up.
Yeah, there's a couple of things. Playing off that directly, this is a conversation Mark and I have had quite a lot. Really has to do with the fatigue that the healthcare workers feel day after day after day, and it becomes normalized. And so I found in my emergency department, I feel like the PPE police, because people get lax about it. And so striking that right balance between, I think what Mark would call the ritualization of putting on a full-on PAPR and being in it, and that being a signal to everyone else of, hey, we are in a dangerous environment. There are people who are asymptomatic, who may or may not be exposing you, and that we as the healthcare providers and teams need to really be cognizant of it. And that's the danger of this whole disease, is the latency between exposure and symptoms, or lack of symptoms, and the contagiousness. And so I think really finding ways and strategies within our teams, and then also as you are developing the PPE, to have it be able to be comfortable enough to wear, and so you're actually having the signaling.
Right.
To your previous part, quick on the psychological component, or the demand.
I'm glad you mentioned that, because when I wear PPE, I feel claustrophobic.
Yeah.
I'm sweating more. I can feel my heart pounding. I'm hungry, and I can't pee. And there's this kind of sense of gloom and stream. It's just this sense that you kind of get used to most of it, but it doesn't quite feel like something that was ever properly designed for 4, 6, or 8 hours. And so that's an incredible emotional toil, which is never really measured anywhere properly, but is leading to a variety of literature suggesting a lot of burnout, people wanting to retire early, leave acute care medicine primarily. These are serious issues, especially when we think about health workforce, both in not just in developed countries, but in developing countries. So here's my question to the whole panel, and raise your hand and I'll call on you. Are we designed right now to learn? Are we harvesting the learning from our own departments, our hospitals, our counties, our countries? Is there a learning mechanism ongoing, or are we just kind of stumbling in the dark 6 months into this? Who wants to take a stab at that? And how do we build more of a learning system where we're bringing these messages together in a more effective, granular way, and using industrial quality methods like PDSA cycles or quality improvement tools? What do you think? Who wants to take a stab at that? Brett?
I just want to build just the bottom part of the framework for that part of the discussion, and really acknowledge that everyone is really in survival mode. Even our administrators trying to figure out operations, there's not been the bandwidth for that, which is why this hopefully coming trough before the potential tsunami that will include flu and RSV and really just obliterate what we've used to be able to our flex spaces.
Yeah.
We can start designing that in. Part of that will then include on the front end during that trough, really having a healthcare workforce feel and know that we are going to find ways to better protect them in the workplace, to better support them and their families as well.
So we're going back to applied trust, right? So how do we build trust building measures, right?
Yep. So understanding that framework, I'm very eager to hear from our colleagues.
Yep. Mark, what do you think? How do you build a learning system when there's so much misinformation, so-called infodemics? There's so much lack of communitarian spirit. How do you build that in a space in a short amount of time?
Well, I think you have to think about the community in terms of the clinic community, and then the community at large. And I think these are two different issues. I think one of the biggest lessons that we've learned from past pandemics is the importance of not dealing with individuals as the unit of analysis. It has to be the household. Whether you're a healthcare provider or whether you're a patient, you're really concerned with the unit of analysis that's not just the sick person, but everyone around them. If you take a look at the United States as an example, 20% of the United States live in multi-generational families. And of ethnic minority groups, that is more like 26 to 28%, depending on the minority group you're in. 40% of healthcare workers or frontline essential workers, not just doctors and nurses, but all the way down the line here, are people who are living in or members of minority groups. And they have large numbers of them are living in multi-generational households. So not only are they going to work, but they're coming home and placing their family members at possible risk. This is true whether you're a healthcare worker or a bus driver, or whether you're someone who's in the sanitation department, it doesn't matter. So what is going to invoke trust is not just words and messages. It really is acts, activities, types of support, types of monitoring, people knowing that if they become ill, that we have their back. And this is as true of emergency room doctors as it is true of all essential workers, and we are not doing that. If you want to build trust, it's very easy to lose trust. It's very difficult to build trust. And think about the people you trust in your own life. When do you trust them? What is the metric of trust? The metric of trust is reciprocity. It's being there for them at the end of the day. And that's what we need to be doing. And if you look at our approach to COVID-19 right now, you have, and just look at the news, just the content analysis of news, it's all really based on testing discourse, possibly tracing discourse, almost nothing on support of how you isolate or quarantine in place. We have not prepared the American population for how to even deal with people who are either sick or have just been informed that they have a positive test. They don't know what the hell to do. And many of them do not have the wherewithal to be really isolating in place. They don't know what to do. They don't know where to go. And this is true of all healthcare workers, all people in essential healthcare, essential services, and we could go all the way down the line. If we want to evoke trust, and if you look at what evoke trust, or just take Ebola as an example, the countries that did well with Ebola because households that were possibly infected or out of quarantine were taken care of by other family members, by their community who gave them food. Food security has to be a huge part of any pandemic response. We have to be thinking, what is it that's going to keep the well-being of that family healthy? If you have someone to back and take care of their family, that's a way of invoking trust.
I like that. That's a very powerful message. So, I mean, if we think about how much money it takes to prepare for a pandemic versus how much it costs to be unprepared, done from an international perspective, from Wadham's perspective, going back 30 years in your work with the DoD. I mean, how did we drop the ball in being unprepared for the pandemic, and how can we gain ground given the calamity that's rolling out right now? Yesterday in the U.S., it was reported that annualized, the U.S. has lost a third of its GDP in the last 3 months. So what are some lessons for preparedness there, Don?
Multiple lessons, and preparedness can be likened to prevention in healthcare writ large. I always use the example, I didn't have a heart attack yesterday, which is important to me, my kids, my wife. People down the block, not so much. I'm sure they wish me well, but it's hard to put a price tag on prevention. It's hard to put a price tag on preparedness. I don't remember somebody earlier, I think it was Brad, talked about the business model of healthcare. The average, in the richest nation in the world, the average hospital runs at somewhere between a 1% and a 2% positive margin. Many of them lose money every year. So, buying those extra pharmaceuticals, having extra bags of, ringers, that just doesn't happen. Mm-hmm. And even before the pandemic, we had shortages of IV fluids, certain pharmaceuticals. So the pandemic has only just made it made it worse. So it's literally looking at being. I have a physician colleague, who calls our community, we're professional pessimists. Being a professional pessimist and say, what could go wrong? What could go wrong? In some parts of our lives, we have that. I'm sure everybody on this call has a local fire department. Some of them are paid, most of them are volunteer. You pay a lot of money, and those people out there for what you hope never happens. In healthcare, we rarely do that. We really don't prepare for it's that doesn't happen here. It happens to someplace else. It's a term I've heard, disaster denial. And when it does happen, we rarely, and your question earlier was great, we rarely look back with brutal honesty and said, okay, we did well on this, we didn't do well on that. And rarely do we take our dirty laundry out and air it honestly and say, wow, we have to get better at this. So a mindset difference, and I'm carrying on. The countries that were mentioned earlier, Singapore, South Korea, Germany, they have that sense of civic duty, they have that sense of response. I have a responsibility to my community. We saw that after 9/11 in the United States, and it gradually disappeared. We need to bring that back. We need to have a sense of we're all in this together. That's a great tagline, but I don't see it in action.
Absolutely.
Brad, you want to jump in on that?
Yeah, no, please. I agree with you wholeheartedly. I think it's very, very challenging when you have numbers coming out from our insurance companies that are I don't say record breaking, but they're hundreds of billions of dollars in profits. When a CEO of your healthcare system is making $28 million a year, I can tell you on the front line, everything they're talking about, the margins, rings hollow. And those are the kinds of baseline trust issues that we need to fundamentally solve and very, very visually see at the community level for there to be any trust built. Otherwise, it's just more of the same.
It's really, really great points. I want to talk a little bit about the unintended consequences of the lack of trust and fear has led to a drop of non-COVID acute care by 50 to 70% in April and May. Some may even continue into June. So there's been a huge increase in heart attack mortality at home, a huge increase in stroke death. In fact, a remarkable backlog in semi-elective surgeries for cancer patients. So really an extraordinary increase in NCDs, non-communicable disease problems, which is probably going to be with us for years to come. We've learned from SARS in Hong Kong and Toronto that it took between 9 and 15 months to address the backlog, and those were very contained pandemics. We're at a whole different stage now where some estimates suggest that it might take, as of now, assuming everything goes back to normal, and it won't, at least 18 months. Some of the challenges around the training, which I want to really throw this out, is a lot of training has stopped or has been mitigated. Many residents or students were kept from clinical environments. And from a training perspective, how are we going to prepare the present and next generation of students and residents and nurses and physicians who have been kept from training and still not doing face-to-face training? What are the implications for the training workforce issues, the planning issues in systems that are already strained before? Who wants to take a stab at that? Rami?
Yeah, so I mean, yes, there has been a significant decrease in volume from the beginning of the pandemic until now, although in the United States, at least, where I'm at in the Midwest in Indianapolis, those volumes are starting to come back, as the summer season, comes full force, and we have the usual, summer problems of trauma and other, pathologies coming through. So there was definitely a lull in training, both in the sort of a complete exclusion of medical students from the last part of their training, especially those senior or those last year students, as well as, in the early onset of the pandemic, many residents were not even allowed to participate in the care of patients, which put an significant extraneous strain on myself and my other attending physician colleagues having to do all the critical aspects of the most, critical patients and stuff. So that's obviously, the pendulum has swung back to a more normalized state now that, there's been additional training in PPE and how to protect yourself and the staff and the teams, and some of those modifications to how to run acute resuscitations. So in some ways, the crisis has led to opportunities, right? The opportunity to train specifically in a pandemic response, how to provide leadership in otherwise, is now sort of a austere in-hospital environment, right? So there's been, again, pluses and minuses, but I think some of the pluses are some different opportunities to really show excellent leadership. And in the lack of volume or lack of opportunities for, say, general surgeons, anesthesiologists, where a lot of their elective procedures and some of their training will essentially grind to a halt, I think there have been other opportunities for them to develop in other areas. And as I think now things are getting more normalized, their training is sort of back on track. So I think it's really just more of a temporary, it was a temporary issue, but I think it's something we definitely have to take in consideration moving forward with future pandemics. And I know as a simulation expert, we've tried to move a lot of our training to an online platform. And even, for example, just training some of my emergency medicine interns on, for example, recently how to do death notification. That was an in-person thing where we had actors, standardized patient actors, where they had to go into a room and train the, or sort of show content expertise or ability to provide a death notification. We actually did it quite successfully all on a Zoom platform, and we're able to provide them good feedback in real time. And so again, it provided an opportunity for us to have some innovative approaches to overcome some of those obstacles.
If I can just build on that real quick. Yeah. I honestly think that this trough is the opportunity for us to build the structural components that will allow for that to be deployed this winter effectively, because honestly, the tsunami that's coming, I think, can't really be understated, or the potential for it, and we need to be prepared so we don't have that lost time. Additionally, having people be much more comfortable with coming forth with expressing what they need, or with embracing vulnerability and reframing the way we're trained in medicine and healthcare around invulnerability to actually break that down and have people be able to speak to what they need mentally, physically, emotionally across the board, so we don't end up with our colleagues and ourselves at the end of our wits at a much lower threshold, because this is going to be going on for a long time. Sorry. Yeah. Thank you.
Great points. We forget that AIDS is still with us now 40 years later. We don't have a vaccine. It's killed over 35 million people. We've learned to live with it. You can, the longevity of people with AIDS can be 30 years and they live well. But let's not forget that we could be looking back 5 years from now, not have a vaccine. And I'm curious to hear your thoughts on what you think on what you're hearing about vaccines. And I'll tell you what my bias is. So who thinks there's going to be a vaccine in the next 3 months? How about 6 months? How about 9 months?
Maybe.
Maybe, and I'll tell you, I have some very, very brilliant infectious disease physicians who said, I'm not getting in the front of the line to get this when this first comes out.
So maybe the more important question is not when there'll be a vaccine, but when will it be safe and people feel comfortable getting a vaccine like you get for polio or MMR? And I would argue that it's going to be at least 18 to 24 months for that, based on past experience and the time it takes to make the vaccine, to produce it across the world, and to make it available safely. So Luis is shaking his head violently. Luis.
Yes, it's a topic that I had in my mind the last days.
Go ahead, Luis.
Sorry, can you hear me?
Yes.
Sorry, can you hear me? Fantastic. I'm sorry for that. Yes, it's an important topic that we have been discussing lately because it's not only that we can have one or two vaccines available in the next 12 months, perhaps. The problem is that we consider this situation as the geopolitical issue of our time. And this is another perspective that we would like to address, and I would like to put on this table, because we can see that countries with first access to the vaccine will be in a better position to reboot the economy and social life. So that's really important. So it's there is a risk to have this unhealthy competition for that and for that position. So we need to understand that once that we have one or perhaps two vaccines, we will require billions of doses in a situation without precedent. I mean, without precedent about production, the development, production, and distribution. I can recall any other situation that could be similar to this. So, and we also are seeing some vaccine nationalism that we need to avoid at this moment. Perhaps this is the example of the coalition that we need. There is, for example, the COVAX coalition, which is led with Gavi, the Coalition for Epidemic Preparedness and Innovation, and the World Health Organization. And unfortunately, Mexico is part of this coalition too. So this is perhaps an example of international collaboration preparing the field for the next 12 months. So we can share the development, the production, the distribution, and more important, to ensure equitable access to the vaccines, not only for countries, but also inside the countries. Who has access to the vaccine in a country, in Mexico or the United States? What is the difference about that? Who is in the front of the line? So we have to first work in this coalition as a global, internationally, and then we have to also prepare our distribution plans in our country according to ensuring equitable access to this product. No, I mean, unfortunately, the spread of the infection is accelerated, and the vaccine, I see that the vaccine is our only way to exit this pandemic.
So, Luis, that's a great point. This whole question of vaccine nationalism, and I read this article interview with Peter Marks from the FDA saying that getting vaccines for COVID is like masks dropping out in an airplane when you have a depressurized situation, except the masks don't just drop in first class.
Yeah.
And so it's a nice analogy to think about that. And so in all safety elements around the world, if transportation or systems, we always think about equitable. Everybody must have the equivalent access. So how do we implement that in an honest, transparent, and judiciously well done way? Don, you got your hand up?
Yes, and so does Mark, I believe, after me. I see a huge issue here that's common in many epidemics, and Mark already alluded to this once. There's a huge cultural, the elephant in the room to me is cultural. The people who need this vaccine the most, assuming a vaccine miraculously appears, the people who need it most, the people that are bearing the greatest burden of morbidity and mortality, do not trust the system.
Yeah.
Do not trust. They just don't trust it. That's a problem in testing. We don't have enough minority and low income. I recall H1N1 vaccinations in Washington, D.C. In my neighborhood on Capitol Hill, the line was around the block. The Department of Health was administering it. Across the river in the lower socioeconomic part of town, it was a desert. There was the team was sitting there looking at each other because the community did not trust the authority. That I see as the biggest challenge to A, a vaccine, and B, getting this under control through vaccination.
So going back to our earlier theme, the lack of trust that has been getting worse because of lack of preparedness and lack of supplies and miscommunication leads to a lack of trust and willingness to get the vaccine, and emboldens the anti-vaxxers out there and all the other pseudoscientists who argue against that. Mark, you wanted to respond to an earlier point?
Yeah, a couple of points. First of all, with respect to vaccines, let's be brutally honest here. It's not just a question of we have these 4 really good candidate vaccines now. Who knows? We may find out that that they're promising within the next 3 or 6 months. And then we have all the issues of how do you distribute them and the ethics of who's in line. But we have no idea how long these vaccines will last. We have no idea about our antibody levels and how long people will be immune if they have had this illness. We don't know any of that. It's not our people willing to get a vaccine. It may end up being our people willing to get a vaccine every 6 months. It's just the whole notion of a vaccine as a magic bullet really has to be unpacked. In terms of people who are unwilling to get a vaccine, I would just say here there's a big difference between vaccine hesitant people and people who are vaccine who just frankly don't want it. With H1N1, I did some research on vaccination, and many of the people who said that they were vaccine hesitant were the first ones in line to get the vaccine. But because they were vaccine hesitant, not for vaccines in general, but for specific kinds of vaccines. We've just lived through the disaster of the dengue vaccine, right? That didn't work out all that well. What worries me, Paul, is going back to a point you skipped over very quickly, which was collateral damage. I think the collateral damage issue is hugely important for the public in terms of trust. Right now, globally, we have 23 countries that have suspended their measles vaccination program. That scares the hell out of me as someone who's worked on measles and pneumonia overseas. We have our HIV and our tuberculosis programs in many countries have been put on hold. And this is going to have huge issues. We saw this with Ebola, with both malaria, maternal mortality, measles that spiked up. These are huge issues, and they happen quickly. It's not something that's going to happen a year or 2 or 3 years from now. This is something that will happen in real time in a matter of months. And I think for the public, even people who have been lukewarm about their efforts to engage in any type of preventive behavior related to COVID-19, I don't think the public has an idea of just what the impact is of delay of services, both in terms of human lives and in terms of cost for the healthcare system. And I think that we need to be addressing this issue far more for the public. It's not just a question that your beds are full of COVID-19 cases. It's a question of all the diabetics, people with cancer, people have heart problems who aren't coming in routinely or who are afraid to come into a hospital at this point in time. We don't really have COVID-19 hospitals set up. We have some boards set up. There's a lot of mistrust about going into a healthcare setting for any type of procedure because you're putting yourself at great risk. This is a disaster.
Incredible points. We need one more hour just to unpack your last comments, Mark. We have about 6 minutes to go. So what I'd like to do, starting with the order, a final comment, and I'd like you to focus on one positive thing that you've seen, perhaps an unintended consequence, or something you think that is particularly uniquely reflective and nurturing as we go forward in your own microsystems, something that we can offer guidance to our listeners. Rami?
I mean, I think from the front line, the thing that I think I appreciate the most is the even stronger sense of closeness between my interprofessional colleagues and myself, that we're in this together. We're sort of fighting a war that's just no end in sight. And in a lot of ways, as tough as it's been, it's brought a lot of us closer together in a way that helps, I think, all of our resilience. So.
Okay, well, I have perhaps three ideas in mind of the general lessons that we are seeing here from Mexico and what is happening in the world. So perhaps for me is the lesson that we have to understand, and this needs to be really clear, that COVID-19 is not a political crisis. We have to see it as social crisis. I see a challenge there, but that is the perspective that I believe would be essential for the following months. We also have to remember that the success of our global response of these pandemics will rely always in the response of the weakest health and social systems. We also have to consider that. And finally, my last idea that I would like to share with you is that COVID-19, I would like to stress, is not the 2030 agenda. Nevertheless, I am really convinced that COVID could be the buffer to think again how to achieve all the sustainable goals.
Thank you for that. Brad?
So building onto the community, whether it be the community of the healthcare workers who now have a lot more unity, but I think that's a hugely important point. And taking that kind of the macro to see the upwelling of support from our communities for us as healthcare workers and for essential workers across the board has been incredible. And that's honestly led in March to a group of us being able to come together to start trying to put together the supports for the frontline healthcare workforce. And this is medical anthropologists and public health colleagues, folks and psychologists all coming together to try and build an intervention that fills a gap that helps us get towards the community-based pandemic preparedness model that we need to build. And HCW hosted is now formalizing and trying to be rolled out further. And the mindset that we need to link the community and the communication from our clinical world to our community members and all the way back up, feeding back up at the loop to leadership, and I think is incredibly important. And understanding that when we're practicing medicine at the bedside, we also need to be practicing public health and be thinking that way. And for the community members to feel like they have a voice and our team members have a voice is important. And it's been wonderful to see it start happening.
Thank you. Don?
I'll echo my colleagues what they said. I think one of the things to realize is that COVID is a sneaky disease. People aren't dying in the streets, so it's hard to recognize. But people are dying, and more people are dying than should. I think there needs to be a realignment of the culture and the community. We as a nation, we as a world, it was done during World War II, it was done after 9/11. There's different times, but understand that public health 101. There are ways to track, there are ways to counter this, there are ways to address this without closing everything down. But that requires collaboration. That requires, we have ways of doing contact tracing, and that doesn't mean the government is looking for your bank account, or that Bill Gates is going to chip you so the New World Order can come in. But, it's coming to that, and I think part of it is also that it shows that as a species we're very resilient, and if we can look beyond and look beyond our self-interest and stop trying to justify things with facts taken out of context, we can and we will get over this. But it's going to take a community effort, and that's a grassroots effort.
Thank you. Mark?
Yeah, what gives me hope is you guys. I'm really delighted to be on this panel. The reason I say that is that you're absolutely right. The fault lines of both the medical system and the public health system have been laid bare, no matter what country you're in, every time you have a pandemic that lasts more than a couple months. You can handle things for a couple months, but once it becomes protracted, you start seeing the fault lines. And what gives me hope is that recognizing the fault lines is mobilizing the medical community to be more politically active and be involved in healthcare reform. For years, I have been waiting for you guys to step up to the plate, be more outspoken. Now we have the most ridiculous election. I probably shouldn't say this, but it's a ridiculous election of what's happening in this country. And we need healthcare providers on the front lines speaking up and talking to the American public. And for the first time, in my lifetime, the American public really wants to hear from you guys. They want to understand more about what's going on. Unfortunately, a lot of healthcare providers have been muzzled. They can't speak out, but when they do speak out, it's incredibly powerful. So that gives me hope. And I think the other thing that gives me hope in another another part of my life is looking at the public understanding of science and how we have to rethink the education system all the way down to the elementary school level of what it is we're teaching children about how to be healthy, about a disease. We should not be introducing masks out of the clear blue sky. People should understand the importance of basic, very, very basic epi principles at a very young age. And I think that there will be an opportunity to rethink our education system to introduce this. So those two things give me some hope.
So I want to thank you guys. This has been an incredible panel, helping us to think about the interdependencies between technology, between welfare, between wellness, and the SDGs, and particularly thinking about the importance of systems thinking and how do we reorganize our physical and organizational elements in society in order to address a healthy, resilient, and productive community. It can't be done without these core issues, and it's going to require the incredible strength and resilience of all these communities, both in healthcare as well as in the community, as well as addressing our political systems that have to be kept in check, because we know that there's a constant balance there as well. So thank you again for participating. So I want to thank Dr. Luis Martinez, Dr. Rami Ahmed, Professor Don Donahue, Dr. Brad Dreyfuss, and Professor Mark Nichter. Thank you so much for joining us on this incredible panel. Goodbye now.